So it's actually a great pleasure for the next line of speakers. They're all they're three young, sort of rising surgeons. I know all three of them personally, and they're excellent clinicians and researchers. So first, we're going to have Dr. Lucas Sideris, who's an assistant professor at University of Montreal. He's a hepatobiliary surgeon and surgical oncology surgeon at Rosemont de Maisonneuve. He's done training in, besides Montreal, he spent several years in France training with some of the best surgical oncologists that I know of. And he's going to talk to us about when the tumor is invading the mesentery and the lymph nodes, if I'm correct. So I'd like to welcome Dr. Lucas Sideris.
So thank you very much, Dr. Nitrakos, and I wish to thank the committee for inviting me to give this talk. So since I'm a Francophone, my slides are written in French, but I've seen that I think all people in this audience speak English, so I will give my talk in English, but I will be happy to hear questions in French, of course, if you wish, at the end. So my topic is to deal about the therapeutic approach of endocrine tumors that are invading mesentery and lymph nodes. So, just to give you a small overview, I know that Dr. Rivera has already done so, but we know that these tumors are rare. The incidence is about 4 per 100,000 people, and you can see just as comparison that adenocarcinomas of the esophagus, the rate is about 5 per 100,000, and gastric cancer is 9, so it's not that rare. So surgeons, clinicians might have great chances of seeing patients with this disease. We know, of course, that these tumors can secrete bioactive hormones and give symptoms. And, of course, we spoke about carcinoid tumors and pancreatic neuroendocrine tumors, which are part of a big family of the gastroenteropancreatic tumors, neuroendocrine tumors. The metastases in the lymph nodes in the mesentery, for the big majority of these tumors, they originate from carcinoid tumors arising from the small bowel. This is the vast majority. So this will be the main topic of my presentation. So just to give you some statistics about these carcinoid tumors, and we have just to mention as a definition that the classical definition of carcinoid tumor is a neuroendocrine tumor arising from the digestive tube. The bronchi, of course, in the lungs are part of this, if you see the embryology of the digestive tract. And in the last series of the SEER, the American SEER on 35,000 patients, you can see that the most frequent site of primary neuroendocrine tumor is from the lungs, 30%, and then it's the small bowel. So the main characteristic of these tumors is a very slow growth over years, and a long survival, even in the presence of metastatic disease. Many patients are not asymptomatic or have non-specific symptoms, and of course this is a reason why the diagnosis is often delayed. And many times you can have a discovery which is not predictive. For instance, if we operate on a patient with appendicitis, we can find a neuroendocrine tumor of the appendix. The major characteristic of this tumor, of course, is that some of them have the potential to secrete hormones that can give syndromes. But these tumors are not the majority of these tumors, because I would say that a florid syndrome, like the carcinoid syndrome, arises only in about 10% of patients. But about 40% of patients can have somehow a secretion that can, raise our attention. And most of the time, these tumors arise from the midgut, small bowel especially. And when we have this syndrome, it comes from the systemic release of these hormones. So they go in the blood and cause the syndrome. So here are the principal tools that we have to treat these tumors. We have two big parts of treatment. You can have the local regional approach and the systemic approach. My part of the talk would be dealing with the surgery, of course, and during the day you will hear from all the other modalities that you can see here, the somatostatin analogs, the interferon, treatments for pancreatic nets, chemotherapy, targeted radiation therapy, and targeted therapies. So, lymph node disease. What are the principles of treatment? Well, surgery is a mainstay of this treatment, and I will explain you why. And this surgery can be separated into two parts: surgery of the primary tumor and cytoreduction of metastatic disease. So just to make this presentation practical, I have here a clinical patient. So this is a 49-year-old man, good health, but he's been having diarrhea since many years with no clear explanation, no flushing, and he didn't lose weight, he was not tired, he just had that diarrhea. So his general status was fine. So he consulted his family physician, and then he was referred to a gastroenterologist. And the gastroenterologist did some tests, including chromogranin A in the serum, and it was high. So, of course, the suspicion of a neuroendocrine tumor was high. And he also did a test in the urines, the 5-HIA, which is the inactive metabolite of serotonin, which is secreted classically in mid-gut carcinoid tumors. So you see here you see the CT scan of this patient, and you can see, if this is working, yes, there's a mass here in the mesentery of this patient of 5 by 4 centimeters with other small nodules which are, of course, suspicious of metastatic lymph node disease. No primary tumor is seen in the small bowel, appendix is normal, and there is no evidence of metastatic disease elsewhere. So the question we must ask is, what would be the best therapeutic approach for a patient like this? Second case, a 60-year-old man. He's been having diarrhea and flushing for also many years, but also in a good general status, no weight loss, he was working, and he was also seen by a gastroenterologist, and a scan was performed, and you can see here a similar type of disease, but a much larger mass of the mesentery, and you can see here the retraction of the small bowel on this mass, and of course, multiple metastatic lymph nodes around this. Once again, on the CT scan, the primary tumor is not seen, and I want to stress the fact that primary tumors are hard to see on CT scans, especially when they arise from the small bowel. This patient also had multiple bilateral metastasis in the liver. So, we'll come back to the cases a bit later. I will just describe what are the treatment approaches that we can have. Surgery is mainstay of treatment of these patients, whatever the stage, when it is technically feasible and safe in a patient in a good status, of course. First thing we have to deal is the primary tumor, and of course then the metastatic disease. Metastases can arise in the lymph nodes, in the liver, or can also develop as peritoneal carcinomatosis, or a mix of all these. They can be all together in place. We have to remember that surgery is the only modality that could possibly cure patients, especially with localized disease. So when we have a patient with a localized disease, surgery is very important. So, surgery of the primary tumor. If we have a patient with a primary tumor, appendix, small bowel, rectum, pancreas, whatever, the only way to cure these patients is to take the whole tumor out with negative microscopic margins. So, this could cure these patients. And of course, this resection must be oncological. It means that for tumors greater than 2 centimeters, Dr. Amri described us previously that tumors under 2 centimeters are most of the time, sometimes less malignant, but these over 2 centimeters are more malignant. We must have a lymph node sampling. So if we have a tumor of the appendix, to have an adequate lymph node sampling, we need to perform a right colectomy. For a tumor of the small bowel, it is always a case we have to resect some type, the mesentery, which nourishes the small bowel, and of course we do obtain a lymph node sampling. And for these small bowel tumors, even in tumors less than 2 centimeters, they tend to be more aggressive, and we have to harvest some lymph nodes. We always have to take some mesentery out and have some lymph nodes to analyze them. So if we have a patient with metastatic disease, and we do find the primary tumor, we know where it is, even if the patient is not symptomatic, we should try to take it out if it's feasible and if it's safe. Because the problem is with these tumors is that they induce a very high dysplastic reaction with this retraction, as I showed you on the previous CT scan. And these patients can develop bowel obstruction, and this complication is very bad for quality of life, and usually patients die from this condition, and it's very hard to treat. And sometimes when you have to go back, it's too late and it's impossible to take out the primary tumor. So when we can find the primary tumor, even in the presence of metastatic disease, we must try to take it out. Gallbladder, cholecystectomy. Well, usually when we operate on patients for other conditions, even if we find stones in the gallbladder, if the patient is not symptomatic, we never take out the gallbladder en passant. But in these patients, when they have liver mets, it is recommended in guidelines that the gallbladder be taken out because these patients might receive chemoembolization, embolizations, and they may have complications for their related to their gallbladder. So this is written in the guidelines. Of course, I told you all these things, but we have to look into the level of evidence of all these statements. And of course, the level of evidence is not very high. No randomized studies have been performed comparing surgery to medical treatment. So it's based on cohort studies and retrospective analysis. Surgery for metastatic disease. The principles. These neuroendocrine tumors are probably the only indication in oncology to be very aggressive in the treatment of metastatic disease, even if we cannot take out the whole disease out, provided we can resect over 90 or 95% of the disease, because we know that these patients, when we do this, we debulk the tumor and we prolong survival. But of course, this surgery must be safe in a patient in a good condition, again, so we have to take this into account. Once again, the level of evidence of this, no randomized studies, but retrospective analysis, cohort studies. So now we have to divide these metastases in 3 parts. So we have the liver metastases, which will be dealt by Dr. Chaudhary just after me. So I will deal with the extrahepatic intra-abdominal metastases, which are the lymph nodes and peritoneal carcinomatosis. This extrahepatic disease is most of the time the primary tumor which is left in place with lymph nodes. But in about 40% of these patients, there is also a peritoneal carcinomatosis. And we have to know that peritoneal carcinomatosis is very poorly seen on usual imaging techniques like CT scans and PET scans. CT scans always underestimate the extent of peritoneal carcinomatosis. We know, however, that for these patients with a primary tumor in place and with lymph node metastases, surgical cytoreduction, so removal of the primary and the lymph nodes, probably increases survival and quality of life. So we must try to attempt to remove this tumor. The most important thing is to prevent bowel obstruction. And if you see the statistics, about 40% of patients with mid-gut carcinoid tumors with metastatic disease die of bowel obstruction, even if they have liver metastases. So this is why treating the primary tumor, resecting the lymph nodes is very important for these patients. Of course, these tumors are hard to operate on because of this important desmoplastic reaction and sometimes involvement of the superior mesenteric artery, which is the major artery that vascularizes the whole small bowel. We cannot live without small bowel. We can live without large bowel, we can take out the stomach, but small bowel is mandatory for absorption of nutrients, so we cannot resect the whole small bowel. You have to know also that liver metastases from these tumors are often multiple, bilateral, and not always it's not always possible to resect these tumors. We can do local treatment, destructive treatments, but we cannot always destroy them. But the liver is a kind of targeted organ, and we can target therapies. We have more tools to target treatments to the liver than to the whole body or the whole abdomen. So if we can try to resect the whole extrahepatic disease, as I told you previously, be it primary tumor, lymph nodes, or peritoneal carcinomatosis, and confine the disease to the liver, well then the main target of our treatment approach is the liver and makes things much easier. And I just mentioned some of these, and you probably already know about these. So, just a word about surgery for peritoneal carcinomatosis. This is a picture of a patient that was operated on 6 years ago when I was in France. This patient had a small bowel carcinoid, and we knew he had peritoneal carcinomatosis. He also had lymph node metastases, and you can see that these very, very small nodules here are not seen on the CT scan. On the CT scan, we could see maybe 4 or 5 nodules, but when the abdomen was open, you can see hundreds of nodules in there. And every single of these nodules will grow one day and may cause symptoms, ascites, bowel obstruction. So this is why we must never underestimate this disease. And when I was back in France, we performed a study in which we were doing complete cytoreductive surgery of extrahepatic metastatic disease. So we would take out the primary, the lymph nodes when they were metastatic, and the peritoneal carcinomatosis. So of course these surgeries would last for 8, 10, 12 hours, big operations, and we would treat the microscopic remaining disease with hyperthermic chemotherapy, intraperitoneal chemotherapy. The problem with these tumors is that they are not very chemosensitive, and the toxicity of this approach is very high. So there is only one study, the study to which I participated when I was in France, that revealed that there might be a benefit. So let's go back to our patient. Patient number 1. So this patient has a rather small disease. You know, you see this lymph node in the mesentery. It's rather low, far from the mesenteric artery. So I operated on this patient several months ago, and this is a patient with the abdomen open, and you can see here, this is the primary tumor. We did not see the primary tumor on the CT scan. Why? Because the primary tumor was about 1 centimeter, very small. And the patient was not blocked, no bowel obstruction, but you can see the reaction. You can see that it started to attract the small bowel. And within years, this patient would probably develop bowel obstruction. And the other reason why is this here. You see, this is a lymph node that we could see on the CT scan. And you see here the retraction of the small bowel. If we would let this tumor grow, well, this patient would have a big attraction of the whole small bowel on this metastatic disease, and possible bowel obstruction and non-resectable bowel obstruction. So this patient, finally the lymph node was very close to the superior mesenteric artery. I had to clean a big part of the superior mesenteric artery to free the right part of the right mesocolon and the left and the end of the mesentery. So because of this small tumor and because of this big lymph node here, I had to take out 180 centimeters of small bowel, which is about the third of this man's small bowel. Sometimes we also have to take out lymph nodes that are outside the intra-abdominal cavity, because carcinoid tumors also metastasize to para-aortic lymph nodes or iliac lymph nodes. And this is a patient who had a small bowel carcinoid tumor. The primary had been resected years before, and he developed retroperitoneal lymph node metastatic disease, but only in the abdomen. There was no other lymph node metastases, but he also had metastatic liver disease. So I did an operation in which I took out the lymph nodes. You see here, I don't know if you see it well, the aorta with the right iliac vessel and the left iliac artery here. And this is the left iliac vein. This is the ureter, which is here. I put around a small cord. So we had to clean this. These operations take very long, so once again, these patients must be in a good shape to undergo such operations. This is patient number 2. And just by looking at his CT scan, well, I could see that the tumor was not resectable, unfortunately. The tumor was very big. It was invading the head of the pancreas. The metastatic lymph nodes were going behind the pancreas, invading the pancreas, the portal vein, and of course the whole superior mesenteric artery was invaded by this tumor. So this patient was not resectable because there was a high risk of doing major damage to the small bowel. So in patients like this, we have to rely on our colleagues who perform medical treatment. So these are some of these treatment approaches that are available. And of course, it's not my fault, I'm telling you. Sorry about that.
You figured out what it is now. There must be some balloons in the back.
Yeah, I guess, yeah, exactly. So, of course, these treatment approaches will be dealt with a bit later in other presentations. So, conclusions. The cornerstone of treatment is cytoreductive surgery. It increases survival in retrospective series. It controls symptoms, especially we prevent bowel obstruction. And, of course, quality of life is better in these retrospective series once again. The primary tumor, if there is isolated disease, less than 2 centimeters, or local resection with negative margins should be done. The exception being the small bowel, in which even small tumors like the one I showed you, which was only 1 centimeter, can give metastatic disease. If the disease is greater than 2 centimeters and is isolated, an oncologic procedure, surgical procedure must be done. For metastatic disease, we must always attempt to resect the primary tumor. If there are metastatic lymph node disease, we always have to try to completely resect the disease, but if we can confine the disease to the liver, for instance, or resect more than 90 to 95% of the disease, it's perfectly acceptable. For peritoneal carcinomatosis, we must try to perform a complete cytoreductive surgery, so do peritonectomies, take out the disease. But there's a question in regards to the hyperthermic chemotherapy. There is only one study that has performed this, and as I told you previously, the tumor is not very chemosensitive. So in my center, I'm a peritoneal carcinomatosis surgeon. I do not give hyperthermic chemotherapy to these patients. I do, however, the complete surgical cytoreduction. If there is hepatic disease and extrahepatic disease, the aim is try to confine the disease to the liver, to try to resect the disease thereafter, or treat the disease with other modalities. Of course, throughout the cases, and Dr. Metraco stressed this previously, when is the right timing to do medical treatment, surgical treatment? Well, currently it's case by case, but we always have to consider the other treatment modalities maybe earlier in the course of these patients. So thank you, I'm done.